And I think everybody should be able to see that now,
Yes.
I believe. And I should be able to advance my slides. Here we go. Maybe. Okay, Stacy, of course I'm having technical difficulties already. Here we go. All right. Let's talk about Mental Health America of the Heartland very briefly. Our mission is promoting the mental health of the community and improving the quality of life for persons with mental illness. We do that through advocacy, education, and support services. And we serve both Kansas and Missouri. That's where Heartland is Kansas and Missouri. I'm going to give you our website and our phone number. And talk just briefly about our programs. We do a lot of permanent supportive housing for persons with mental health and other disabilities. Those are forever homes. We have them on both sides of the state line. If you're more interested, we've got Janet Cookie Cook's email there. Mental Health Promotion offers workshops and seminars, information and referral to both professionals and to members of the public, and also to certain targeted groups like clergy and lay leaders, social service agencies, law enforcement, first responders, etc. If you are interested, you can contact our own Stacy Davis, who you've already met. We also have advocacy and recovery services. We provide peer support, typically in non-mental health organizations. We also run the longest running consumer operated Warm Line, a non-crisis support service that operates from 9 to 9 every day. Here is its number. We are both a resource for individuals who need somebody to talk to before they reach a crisis point, talk to a peer who's been there. We are also a resource in both of those programs for individuals with lived experience of mental illness that are interested in entering the workforce as a peer specialist. And that's the tagline for Heartland Housing. Objectives today are we're going to identify the causes, symptoms, and behaviors of anxiety and depression. We're going to discuss some non-clinical recovery, wellness, and environmental interventions that will help reduce the symptoms. And we'll suggest some ways to build some rapport, empathetically respond to folks, and some community resources for crisis and recovery and wellness. So let's just start with anxiety disorders. Most of us know these are the most common mental illnesses in America. They affect 19 million of us. Almost half of the major mental illnesses being depression, schizophrenia, bipolar disorder, and anxiety disorders. Those affect 1 in every 3 to 4 Americans, or 54 million. So again, anxiety disorders, very, very common. One of the things that I always point out is that stress is normal, or at least it's very common, especially in our current turbulent times. It's been on the rise since COVID. And anxiety disorder is not the same thing. We heard a lot during COVID about increases in anxiety and anxiety disorders. Sometimes those were confused. I always tell people that anxiety disorders are among my favorite because they, like many illnesses, but more instructive than some of the other mental health conditions, really run on a continuum. And when I talk to sort of John Q. public, I describe this as, you know, you might be just a little quirky, okay? Or you're quirky and it's kind of annoying me. Those two things, hey, it's America. You get to be quirky. You get to be even quirky and annoying. Those aren't a focus of any clinical concern. Folks don't need to do anything at all about those if they're not bothering them. Sometimes our quirks make our lives a little difficult. In those cases, a person may want to seek some kind of support or treatment to deal with their personal quirks. Sometimes a person's quirks makes it impossible for them to function in their daily life. And that's the point where we start talking about those quirks actually being potentially an anxiety disorder or some other disorder. That's the point where we're really concerned, and we want to make sure that that person is getting treatment and support. Again, when I talk about anxiety disorders, and there are quite a few of them, I want to talk about them from sort of the least weird to the most weird. And I'm giving you statistics here. The least odd or weird or hard to understand anxiety disorders, general anxiety disorder, followed by social anxiety disorder, phobias, obsessive compulsive disorder, panic disorder, and post-traumatic stress disorder. You can see the percentages here. And we can see, obviously, that the phobias are among the most common, and social anxiety disorder can be fairly high as well. When we're talking about generalized anxiety disorders, I always point out that generalized anxiety disorder is not usually treated in mental health clinics or service delivery systems, because generally generalized anxiety disorder is going to manifest itself in the body as a physical illness, maybe pain, a lot of GI distress, acid reflux, GERD, ulcers, etc., or migraine. I often tell people that, getting ahead of myself, I often share with people that my own father probably had undiagnosed generalized anxiety disorder. The man would eat an entire jar of Tums in a week, and he regularly came home with a sick headache and had to lie down. Ultimately, developed high blood pressure due to his stress and probably undiagnosed, untreated anxiety disorder, and passed away of a stroke at the age of 64. Now, nobody in my family ever dies before their 90s, so he was very unusual. Had we really thought about it, we'd realize that probably he was suffering from an anxiety disorder and worked with that rather than letting him continue to take high blood pressure medications and continue to eat Tums like they were bonbons. Let's move now to social anxiety disorder. Again, this is another one that usually folks don't get treated in the mental health system because they don't show up. Social anxiety disorder is a very unusual amount of stress and fear and discomfort in social situations. Often that's in large groups of people. It can be just in groups of strangers. And if you think about it for just a second, you think about, wow, I have social anxiety disorder. I really don't want to go out. I really don't want to be around a lot of people. I really don't want to be around people I don't know. Why would I go to a place where I don't know anybody and sit in a waiting room full of people? These folks usually simply don't show up. They tend to go under the radar for all of us. And many times folks just work around them. I have a number of friends and colleagues who are probably right on the edge of having a full-blown social anxiety disorder. They're in the very quirky, and it makes their life difficult, but they work around it. They have very intentionally chosen positions where they're working from home. They don't need to go out and see anybody in person. Moving to phobias, very common. Something went ahead of me. Very, very common. Many of us have, in some point in our lives, had a phobia. When we were kids, we might have had a fear of the dark. We might have had a fear of dogs or cats or whatever. Most of us grow out of those phobias. Some of us continue to have phobias. And again, this is one where, okay, you're a little quirky. Okay, I personally terrified of heights. I probably go from quirky to quirky and annoying with my husband, who always says, you know, there's really, really good therapy to get you past your fear of heights. I've chosen just to work around it. He can be the one who gets on the ladder to change a light bulb, and I absolutely do not do any skydiving or hang gliding on my vacations. But were I so phobic, so upset and fearful about heights, or if someone even said, hey, hang gliding, and I became very distressed, I might want to get some help for that. Again, very often folks simply live with their phobias and work around it. Move to obsessive compulsive disorder. Okay, let's just start with, everyone says, oh, geez, you're obsessive. Oh, you're so compulsive about that. Many of us are happier when we have routines. And most folks I know notice that in the morning, they have just a routine where they get up, they start the coffee, they start the breakfast, they go take the shower while the coffee's brewing, come back, grab the coffee, read the paper, whatever. They have routines, right? And they go about those because who wants to make all those decisions in any given morning, right? Our brains just don't even need to work on that. But if something's disrupted, okay, you have house guests that get in the shower and use the bathroom when you're normally doing it, or you're out of coffee or whatever, you feel a little uneasy. That's a typical routine. That does not mean you have obsessive compulsive disorder. It doesn't even necessarily mean that you're quirky. It means you're pretty normal. But with obsessive compulsive disorder, what the person has is obsessions. And these are here's the official, recurrent intrusive thoughts. These are often of bad things happening. For example, most of us will check to make sure the coffee pot, the iron, and the curling iron are all off before we leave the home so that we don't burn the house down, right? That's a routine. It's a good idea. But a person who's got an obsession may, in the back of their head, almost like a tape loop, be over and over beset with the thought, the house is going to burn down, the house is going to burn down, the house is going to burn down. What often then happens is both to sort of relieve some of that anxiety and also often to sort of guard against that bad thing from happening, is a person will develop a compulsion, which is a ritualized kind of behavior. In the case of someone whose obsession is the house is going to burn down, they may have to plug and unplug that curling iron 5 times or 25 times or 36 times. They may need to check every burner on the stove a certain number of times. Now I'm going to go back for just a second to the quirky. Okay. If you're a little quirky and you just like to check things a little bit, that's fine. It may be a little annoying. Got a person in my family who is one of those who absolutely needs to double check the stove 2 or 3 times. Often that's a simple workaround. He's not late for work because I've reset the clocks in the house by 5 minutes. So he has time to perform his rituals, his compulsions, and no harm, no foul. Sometimes, though, those can be very disruptive. A colleague of mine's husband had a thing about vacuuming lines in the floor and the carpet, and everything was all well and good right up until they had a baby who started to walk. And every time the baby walked across the floor and disturbed the lines in the carpet, the dad became very, very upset, yelling and screaming, needed to vacuum again. And the whole evening descended into an upset dad, a crying baby, and a vacuum cleaner running almost nonstop. This was the point where, yeah, we probably need to get some help for that particular compulsion and those obsessions. So there's a couple of stories and examples, and if we have more time, I have scads of these. Panic disorder. When I can see folks in the room, I usually say, okay, who in this room has ever had a panic attack? And usually over half the hands go up. A panic attack is not the same as a panic disorder. Panic attacks are very, very common, and a person has to have a fair number of them in a relatively short period of time for it to qualify as a full-blown disorder. So a quick description and examples. Panic attack is basically all the adrenaline syringes in your head and in your brain getting pushed at the same time for no good reason. In the midst of a panic attack, you feel like you would feel if you were being chased by a saber-toothed tiger or about to get into a terrible car wreck. Your knees get weak, you may be trembling, you may be sweating, your heart's probably racing, you may be short of breath, but there's nothing that's happened. You are standing in line at the grocery store. One panic attack, not a big deal. Multiple panic attacks qualifies as panic disorder and is something that is really pretty easily managed and treated for folks. So treatment options. Well, one, you can simply ignore it, right? Simply ignore the fact that, the person in my house has these compulsions. Simply ignore the fact that I'm afraid of heights, or you work around it. My husband has to get up in the ladder. The Anxiety and Phobia Workbook by Edmund Bourne. Huge fan. This is a workbook that helps people to just simply get a handle on how to manage the symptoms of anxiety disorders and phobias. Prime example is with panic attacks. I personally have used this book because of panic attacks. And what I learned is, wow, I know exactly what my body feels like when one's coming on. I know exactly how long I've got before it hits me. And I simply remove myself from whatever situation. Maybe I'm at the grocery store and I tell the lady I forgot my wallet in the car. I go out to the car. I practice the relaxation, centering, breathing exercises that I've learned from the book. Odds are I'm not going to have a panic attack. If I do, I'm in a safe place. I'm not embarrassed. I am not going to have some very well-meaning bystander trying to help me, which not only adds to the embarrassment, but also often results in someone calling an ambulance and me going to the hospital and having a big bill for nothing more than an anxiety attack, because of course they've hooked me up to everything because they're pretty sure I'm having a heart attack or something based on my symptoms. So that is an option, always helpful. Self-help and support groups exist for all of the anxiety disorders, and again can be helpful as we learn strategies that other folks have developed on their own to deal with their anxiety. And of course, psychotherapy is helpful. There are different psychotherapies typically used for things like phobias that are used for panic attacks, and medication works very, very quickly with the anxiety disorders, in contrast to medications for some of the other mental illness that take some time to get kind of up to the proper levels in your body. There are some pretty alarming side effects to any and all medication, including, of course, aspirin. But particularly with the anxiety disorders, some of the side effects to those make them maybe not the best idea for some individuals. Those self-helps and the psychotherapy are available online and can be very helpful, particularly if someone has got a social anxiety disorder where they don't want to get out among groups. The advent of online therapy and online support groups has been incredibly beneficial. And then two, some of us have transportation barriers, et cetera, but there are also local in-person self-help and support groups that are helpful as well. Again, all of these options are in play for generalized anxiety disorder, social anxiety disorder, phobias, obsessive compulsive disorder, and panic disorder. Okay, all of these, depending on how badly the person's impacted, they can ignore them, they can work around them, they can try some self-help work, or they can try self-help in addition to psychotherapy, medication, etc. Or may find that psychotherapy and medication is where they need to start. So let's talk about post-traumatic stress disorder, because this is sort of categorically different, even though it is still in the category of anxiety disorders. Trauma, when we talk about post-traumatic stress disorder, trauma is not the same as what are called ACEs, which are adverse childhood experiences. And sometimes I refer this to the trauma and post-traumatic stress disorder as big T trauma, because they are big, large, often single event traumatic experiences, and trauma in adverse childhood experiences as little t trauma, not because it's less important or less impactful, but because it tends to be smaller, more chronic, more constant assaults on a person's mental health and psyche. So when we're talking about trauma in the context of post-traumatic stress disorder, we're talking about large events that are a threat to life or limb, that are experienced by the person. The person may witness those happening to someone else, or they could actually be something that the person just heard about. And when I talk about life and limb, we really need to think pretty broadly. When we think about trauma, we always think of, oh, okay, it was a rape, or it was a sexual assault, or a physical assault. It might be gun violence. But we also need to think about traumas like my house flooded. There was a tornado, there was a fire, there was a farm accident, there was any one of a number of things that we don't always think about, because this can be something you experienced. Okay, those traumas can be pretty broad. If you think about the fact that it can be something you simply witnessed or heard about, this expands the number of people who are exposed to trauma to include folks like any and all of your first responders, firefighters, EMS, law enforcement, all witness trauma on a regular basis. So do many of our medical professionals. Certainly anyone who's working in the ER sees people who have experienced trauma on a regular basis. One of the interesting things about post-traumatic stress disorder is that the typical onset of the disorder is about 6 weeks or so after the traumatic event either happens to you, you see it happen to someone else, or you hear about it. So it's typically about 6 weeks or so. And during that 6 weeks, the person who's experienced the trauma may be isolating themselves. They may be actively avoiding anything that reminds them of the traumatic event. For example, if it was a car crash, the person may not be willing to drive or ride by where the crash occurred. They may not be willing to even get in a vehicle. The next piece of this, okay, so that's typical, and then they have the flashback, which I'll talk about in a minute. But it's also possible for the onset to be delayed by months, years, and even decades. I always share the example of a dear colleague of mine in grad school who had been worked in Vietnam as a doing medevac. He had obviously witnessed an awful lot of trauma and never, ever, ever had a problem until the mid-90s, when he was working as an EMS, and one afternoon bent down on an overpass to pick up a stretcher and had his first flashback. And in just a second, I'm going to explain why that happened. So it is possible for these to lie in wait. It's also possible for a person to have post-traumatic stress disorder as the result of one trauma one big event. Other people, it may be multiple traumas and they never have post-traumatic stress disorder. Others, it's some magic number or some particular event that causes this. I think of a firefighter who, again, had been a firefighter for years and years and shared with me he'd never had an issue until he went on a call for a kid who had, for a baby who had died of SIDS, of crib death. And that did it for him. His guess is that baby was roughly the same age as his own child. And that was why that one seemed to kind of kick it into being a whole different category there. So I talked about how, you know, the typical first symptoms are some isolation, some numbing, some avoidance of the situation. Also, sometimes in there's increased use of substances to help sort of cope. But the hallmark of post-traumatic stress disorder is the flashback. This is an exact re-experiencing of the event. This is not the same thing as having a hallucination. A hallucination is not real. It's about something that's never been real. And a hallucination is usually not all of your senses at once. A flashback is every single one of your senses is engaged, and it's like you were right back there. So had I been a victim of a rape and I was having a flashback, I would not only feel the weight of the guy's body on me, I would see what the sky above me had looked like, I would smell the scent of the man's cologne, and it would be like I was right back there all over again. As you might expect, that is extremely distressing. Okay, and so I also have feelings of panic during that flashback. So post-traumatic stress disorder happens in part because of how we lay down memories. And I had a veteran once explain this to me, an analogy that has made more sense to me than anything else. And that is, we lay down our memories like we have an invisible filing cabinet in our head, in our brain. So if I want to think about prom, I'm going to go to the drawer that says high school and college, and I'm going to pull that open, and I'm going to find the file that says prom. I'm going to take it out, I'm going to look at it, and there's all the memories of the favorite song, the decorations, my corsage, the first dance, etc. Right? And I thought, oh, that's lovely, and I just put it back in the drawer and I file it away and I look at it again whenever I want to. Now, maybe, possibly, that wasn't a really great night. Maybe my boyfriend and I had a fight and we broke up on prom night. Well, I can get into that file cabinet and go, prom. Oh, wait a minute. That didn't go so well. Let me look at my first boyfriend in college because he treated me like an absolute princess and best guy ever, right? So I can bypass those other memories. With a traumatic event, it's as though we scoop up all of the pieces of the memories and we dump them into the file drawer, and the drawer gets shut, but the drawer actually doesn't have a decent latch on it. And when something happens that reminds us of the event, that's a trigger, the drawer flies open and all of that stuff flies out everywhere. And that is the flashback. And that's the best description I've ever heard of how it works. What is the trigger? Okay, so back to my buddy on the overpass. And if we all could actually dialogue, I'd ask you, what do you think? What do you think it was? Because he'd worked EMS for years. Well, as he went through therapy, he recognized that part of what probably the trigger that day was the precise heat and humidity on that overpass and the sound of life flight coming in, because those mimicked pretty closely the heat and humidity that he experienced in Vietnam and the sound of the chopper coming in to evacuate the wounded soldier that he was working over. Many times people know their triggers. Some folks can take a pretty good guess that their triggers are likely to be, boy, the sight of a gun. And often folks are able to sort of steel themselves that, hey, wow, I've got to go down to the police station to file a report, or down to the courthouse and I'll see the guard and he'll have a gun, and to sort of get themselves emotionally prepared for a situation that could be triggering. Sometimes folks don't know their triggers until they're triggered. What is treatment for post-traumatic stress disorder? Sorry, I'm getting ahead of myself. Treatment for post-traumatic stress disorder does not look like typical psychotherapy. And I find over and over again, when we're out in the public as Mental Health America doing workshops with folks will say, yeah, I got treatment and it didn't help, or it made things worse. There's very specific type of treatments that are really effective with post-traumatic stress disorder, but they're not our typical cognitive behavioral therapy where we're sitting and just talking about it. What treatment really involves is a process, excuse me, very specifically, where a person takes all of that stuff that flew out and very carefully puts it in a file and places it back in the file cabinet where they can look at it if they want. And if they want to skip it, like I chose to skip my not so nice prom night, they can do so. But I always counsel folks, you are looking for someone who is trained in EMDR, trained in trauma. Just regular psychotherapy is not particularly effective with post-traumatic stress disorder. Okay, so how do you know whether your stomach upset might be generalized anxiety disorder? How do you know that your introversion has gone past the point of just being quirky and maybe making your life difficult to, wow, this is really making it hard to get by? How do you know that your rituals have gotten out of hand and qualify as an official anxiety disorder of obsessive compulsive disorder? We always refer folks to take screening tests. These are online. The website is here. They are completely anonymous. This is by no means a substitute for getting an actual assessment, but it is certainly better normed than the Cosmo "Are you a good friend" quiz, right? It gives you a good idea of whether this is something that really would rise to the level of needing treatment. And you can take those for yourself. You also can sort of take them on behalf of somebody else. If there's someone you're concerned about, you can look at those screening quizzes and see whether these are things that a person would need help with. So let's move to depression. And I always tell folks there's two kinds. Okay, there's reactive depression, which is in reaction to an event. It's grief. Nearly all of us are going to experience that at some time in our life if we care about anything at all. And by grief, I'm talking about a loss. It may be a death of someone you care about, loss of a job, a divorce, loss of a relationship. Any one of any kind of loss events can trigger grief, reactive depression. Clinical depression is obviously different because it's not in reaction to an event. So with grief, typically folks start feeling better and more able to cope after a period of several weeks to a month or so. There are still times that are really rough, often holidays, the anniversary of the grief event, the birthday of the person who died, etc. But a person is generally functioning. What we see in some folks is more complicated griefs. Griefs where a person's had multiple losses. We see this a lot in some of our seniors, where a spouse dies, the estate is settled, it's determined that mom or dad can't be safe or cannot manage the farm or the family home, and so we're going to move them into town. Now they've lost not only their home, but there's not space for the possessions. There's not space, you know, for all of the things they've loved. They may have lost their church community, their bowling league. They're in a new environment. If they are moved into an assisted living kind of situation or a nursing facility, they may also lose privacy. A lot of different losses that I sometimes described as either stacked on top of each other or spread out over time. Okay, a person who keeps getting hit by a number of grief events is not necessarily clinically depressed. We just sort of have to think, okay, so if we're talking, let's just say 6-8 weeks before you're starting to feel better, you just about get to the 6th or 8th week and something else hits you and you have to sort of restart the clock. Obviously, grief related to trauma is different and may include post-traumatic stress disorder. And we know with COVID, we had a huge number of losses that are kind of atypical. Loss of the ability to connect with other people, in addition to loss of job and ongoing fear of what might happen. So COVID was kind of a different animal. So major or clinical depression, again, I usually tell people there's no event. It's not in reaction to anything. It just is. It runs at about 5% or so in the general population, but it is much, much higher or comorbid with a number of other illnesses, many of which increase in prevalence as we age. And so we do tend to see depression rates, both reactive depression, grief events, and also major clinical depression at higher rates in our seniors. Obviously, as you get older, you tend to attend more funerals than baby showers, and you are more likely to have cancer, heart attack, diabetes, stroke, or Parkinson's. And you can see if you have one of these illnesses, you go from kind of a 5% risk to 25, all the way up to 70% in complicated diabetes. I always encourage people, if you have, if you've got someone in your family who's got one of these, make sure that they're getting screened and if needed, treated for depression. Sounds really silly, but it's very, very hard to take care of yourself and follow a diabetic diet if you're clinically depressed. And so both the depression worsens and the diabetes doesn't get better. The other piece is that the symptoms of depression are a side effect of many common medications. Okay, so empathy. We all think we understand depression because we've all grieved and we've gotten over it. And often we are not terribly empathetic with folks who've got clinical depression, because when my father died, I was a mess. I could barely go to work for a month and a half, but I got over it. So grab a hold of your bootstraps, pick it up, suck it up, go on. We don't always really get the difference. Again, screening, same site. So let's talk about what it looks like. Depression. We see changes in appetite. Either a person cannot eat enough, it's like they're trying to fill a hole inside themselves with food, or they have no appetite at all. Usually see changes in sleep. A person's got insomnia, they can't stay asleep, or they can't stop sleeping. Loss of interest or pleasure in things that they usually enjoy. Difficulty concentrating or making decisions, kind of a brain fog. Forgetfulness. All of these are very, very common, as is isolating oneself. And we see sadness and tearfulness as well. Worst case scenario, we're seeing hopelessness, feeling that it will never get better. That's the point when therapists get really alarmed, where it's all awful and it's never going to change. Caveat, that's what it looks like in Caucasian women. Depression does not look like that in men, in teens, in seniors, or in persons of color. In men and teens, depression often shows up as anger and rage, irritability, impulsiveness, outbursts, and substance use. Those folks don't get diagnosed with depression. They get diagnosed as being a jerk or a brat. But depression is really what they're struggling with. In seniors and persons of color, it's often somatic complaints. It's pain that has no official reason. And you will see folks, seniors, going to their primary care over and over again because of pain. A friend of mine who works with geriatrics says it's like the organ recital. My back, my knees, my bursitis, my kidney, every freaking thing in the body hurts. But there is no medical cause for it. And not to be silly, but a person who is feeling pain is not likely to go for mental health or immediately suspect depression. They're going to go to their primary care. Often depression gets missed, and often, particularly in seniors, a person has been to their primary care doctor multiple times and ends up dying by suicide as a result of us missing that in primary care and them not getting treatment. Depression treatment options. Okay, this is where our standard, what we all think about for therapy, cognitive behavioral therapy, 6 to 12 sessions, is very effective. Often that is combined with or instead of with pastoral care from a person's faith community. Self-help and support groups are something I always suggest as an adjunct, at least. For some people, this is where they start, but as an adjunct, realizing that you are not alone in your grief, in your loss, in your depression, learning coping strategies from other people who have been there and are there with you is incredibly helpful. Not to over disclose, I would have a terrible, terrible time on my birthday for years after my father died. Sweet little lady in a grief group looked me straight in the eye and she said, "Honey, is there a birthday card you're not receiving in the mail?" And that was it. Coping skill, I simply pulled out one of my old birthday cards. I put it out on the dining room table the week before my birthday. I smile and I think about how much fun all of the birthday cards my father always sent me were, because they were always silly. But there are self-help groups for both grief and loss and for depression and mood disorder. Again, these are online and these can be in person. There are also some great books on grief and workbooks on grief, and the depression workshop, workbook, A Guide for Living with Depression and Manic Depression. We know it's called bipolar now, but it was titled Manic Depression when it was written, by Mary Ellen Copeland, is a great guide. I actually had somebody look at me the other day and said, "You know what, my young adult daughter has picked this up and it's helped immeasurably in addition to therapy." We always talk about therapeutic lifestyle change therapy, which is in the book, The Depression Cure by Stephen Ilardi. And his theory is basically depression is the result of the lousy way that we live today in America. The evidence is we don't see depression in non-industrialized societies. It simply does not exist. They live very differently than we do. His work, his research was done with persons with treatment-resistant depression who had tried every single medication and nothing had worked. And he used the following prescription. First of all, exercise. And we are not talking about you need to join a gym or buy special gear for your house or anything else. We're talking about 30 minutes of aerobic exercise 3 times a week. That is a good walk. Or in my case, it's getting up every single time there's a commercial on the television and walking rapidly up and down the stairs. Omega-3 fatty acids. He has got a prescription that folks can follow. You can pick these up in most health food stores. I always suggest that before anybody adds any supplement, that they talk with their doctor or their pharmacist to make sure there's no interactions. But among other things, we all need to improve our diets. A whole lot less McDonald's and a whole lot more fish and vegetables. Light exposure. 30 minutes a day, bright sunlight without sunglasses, or a light box. This also is helpful with seasonal affective disorder, which we know is something that affects many of us who live in the Northern Hemisphere. Sadly enough, the light exposure does not count coming through your car window. So you actually have to get outside. Anti-rumination strategies. Rumination is thinking of the same thing over and over again, usually negative thoughts. That can be whatever works for a person. It may be prayer, it may be therapy, journaling, calling a friend, doing a pleasant activity, whatever can get a person out of the endless loop of terrible thoughts. Social support. This is honestly, I think, a big piece of why people really struggled and feelings of depression went up so much during COVID, because people could not get the social support that they needed and were used to in order to be mentally well. This can be a support group like we've talked about. It can be FaceTiming people, church groups, organization groups, bowling leagues, quilting clubs, whatever makes you happy, spending time with friends, or just connecting with acquaintances and having human to human in real life kinds of contact. Sleep hygiene, and this is the one I usually get on the biggest rant about. People need 8 hours of sleep a night in a completely dark room in order for the body to flush the junk that's accumulated in your brain out and allow your brain to function effectively. Sadly, there is no supplement that you can buy off the internet that will do this. This is your body repairing itself. It does require a completely dark room. That means, yeah, throw a washcloth over the alarm clock. If you need to look at it at 2 o'clock, 2:15, 2:30 to see that you're still not asleep, great, but don't let that little alarm clock be in there. Phones, again, turn off the light, silence it. Television, I don't care if the sound is on, the light needs to be out. Blackout shades, you name it. 8 hours, it doesn't matter what 8 hours it is as long as it's 8. And your bed should be used for 3 things only. They'll start with S: sleeping, sickness, or sex. Anything else that you're doing in the bed, scrolling your feeds, knitting, reading, watching television, your body doesn't really know what it's supposed to be doing. I always say that, honestly, the best thing we could do for mental health of ourselves and our others would be to focus on our sleep hygiene. Resources. Okay, we've got a crisis text line, and everybody knows about 988, right? 988 will connect you to crisis resources, hopefully in your area. They're working on the geolocating. It's partially in, but there is a text line that folks can use. We have a warm line. I talked about it before. It runs 9 a.m. to 9 p.m. every day, answered by trained consumers, persons with mental illness, as a support and help with coping and recovery strategies. It's got a 1-800 number. And we also do information and referral, helping connect folks to services and understand what they are. I think I'm supposed to leave time for questions, so I'll do that. I thank you all for being here and for your time. My contact information is coming on the screen here. If folks need to reach out to me with questions that I don't answer here today, please feel free. And thank you again. Hope you have a great day.
Thank you so much, Sue. That was a wonderful presentation. We learned a lot. We appreciate that.
Yeah.
I'm going to put in the chat where you can link a link for your certificate and a password. And then we do have a couple questions for you, Sue.
Excellent.
Do you have any recommended resources for depression in persons of color?
Yes, there are a number of different books, etc. What I would suggest is someone sends me their email, because if I jump up and pull those titles off my shelf, I'm going to miss the next question. But Stace, if you could grab that email, we can send out some titles there.
Put your email in the chat, and I will get that down. Okay, we have another question. Why is it that teens and men experience depression in such an external way versus how women tend to express it?
The theory and explanation I've heard is that women, when they're uncomfortable, kind of pull in, right? We're taught to just kind of be quiet and docile about it. Now, hopefully, by the time the next generation comes after me, it won't be that way sort of culturally for most of us, but we're sort of taught to pull it in, whereas our men are sort of taught it's okay to blow it out there. And we all know teenagers and kids are out there in all their feelings all the time. So I think it is largely about the way that we are sort of culturally indoctrinated to handle discomfort.
Okay. Is there any more other questions? Looks like I'm just getting emails on people. We'll give everybody a moment to type in. We have 5 more minutes to type in any questions that you might have.
Oh, Margarita's asking something.
Who?
I saw a raised hand for a second. Oh, flashbacks. How long do they typically last? Typically not terribly long. 15 to 30 minutes, maybe max, sometimes shorter. Sort of depends on the individual. Science behind why our bodies exhibit physical symptoms. Okay, so for the physical symptoms of generalized anxiety disorder, what you've got is a flooding of chemicals in your brain. And obviously, it goes through the bloodstream and is moving throughout your body. And you also may have, physical muscle tension, other tension in your body and your systems. That is part of why you're getting the pain in the stomach upset. For the physical symptoms surrounding depression, Dr. Alardi's theory, and there's a fair amount of evidence to kind of back this up, is that depression is an inflammatory disease, and many of the pieces in his prescription, for example, the exercise tends to reduce inflammation. Also, the omegas tend to reduce inflammation, or at least eating the wrong kinds of fats increases inflammation, and being sedentary increases inflammation. And so that's the sort of the theory behind why folks have have the pain in depression. I hope that was clear.
You have some more questions.
Oh, I can't see the whole chat, so
What did you say with that for individuals with major depression, best interventions were?
it's going to vary by individual. I always think of treatment and recovery as a three-legged stool. Okay, what you may need medication. Okay, sometimes you need medication forever. Sometimes you need it just to get to where you can be successful with psychotherapy. Some people need both. I am a huge fan of self-help and support groups because you typically need some practical strategies from people who've been there and get it to function. And there's often some lifestyle changes that a person needs to make. I liken it to diabetes. Okay, if you've got diabetes, you may simply need to modify your diet, or you may need to take insulin, depending. You also probably need to change your diet in addition. But you also may need the people around you to tell you to stop bringing you cakes and candies. Another analogy is, with most of these illnesses, it's the difference between a sprained ankle, a compound fracture of your leg, and an amputation. In terms of sprained ankle, boy, you're going to need to rest and ice and maybe put an ace bandage on it. Compound fracture, and you might have to get physical therapy. Compound fracture, you're going to be in a cast, but not the rest of your life, right? Before you can go to physical therapy. Amputation, you're probably going to need a prosthesis for the rest of your life, right? So sometimes a helpful analogy. Yes, Stacy.
Would you like to share your journey into the social work field? Someone wants to know your journey.
Oh, brother. I think I was fated or doomed to become a social worker. Everybody in my family on both sides, save for one uncle and my sister, has been in some kind of helping profession, whether it's education or clergy or occupational therapy. So I think I was sort of doomed. What I joke that I ended up in social work because I had pet rats and I couldn't go into psychology because I couldn't do rat lab. But I ended up, frankly, often stumbling into positions and populations because they were interesting to me. Started out in reproductive health by sheer fluke because I went to church with a lady who ran the family planning clinic. I moved out of the area and ended up doing more reproductive health work, but more in education, and then got tapped into a juvenile justice prevention and treatment organization where I was doing prevention curriculum design, and then moved again and ended up doing similar kind of thing in child welfare, and moved again and did all kinds of strange things during graduate school. By sheer fluke, ended up at Mental Health America of the Heartland when they were hiring in Kansas City a very, very long time ago, and have been here ever since, and just love the mission, love helping people, love connecting people to information and services that can change their lives.
And the person that wants information on general anxiety disorders, if you would provide me with your email address in the chat, I will get back with you. Okay, let me see. Okay, that looks like that's it. Thank you, Sue.
Thank you all. I hope you have a terrific afternoon.